Hello students, welcome to Module 1, Maternal Changes in Pregnancy. Right, so for Module 1, these are your learning outcomes. Please make sure that you pull out your modules and go over the objectives. These are the requirements that you are assigned. Please make sure that you spend time reading the assigned reading as well as understanding and applying the content as well as memorizing the vocabulary, all of which you will apply to your clinical practice as well as your rotation, um, and obviously for our test taking purposes. So please make sure that you are, again, we may not cover everything in detail. Definitely in this presentation, we will go over the majority of the concepts. However, we will spend more time in class going over and highlighting the important things that you need to know for your objectives. OB lifelines will be incorporated in our lectures. So basically, number one, OB nurses intervene first before calling the doctor or provider. And as nurses at the bedside in labor and delivery and postpartum, this is a very intimate area of nursing, as you guys will know and may encounter. Again, we spend a lot of time with our patients, coaching them, supporting them, educating them on the process of labor as well as how to transition to postpartum. Again, it's a very intimate area of nursing. So we spend 12 hours at the bedside working with our patients, and so we are the eyes and ears for the providers. So it's very important to make sure that when we are caring for our patients, when it comes to interventions, we always want to make sure that we go with the least invasive measures first before we actually incorporate medical interventions that may be more invasive. Again, it's important for us to make sure that we complete a system assessment, know the patient's baseline, so that way when there are changes in our patient status, you are able to recognize those and report those to the physician. In labor and delivery particularly, you are assigned 1 to 2 patients. However, you may have more than 1 to 2 patients because the baby inside the mom is also a patient. So even though you may not actually see that baby, you're not holding or touching that baby in utero is still your patient. So you are assessing the maternal status as well as the fetal status. And if there's any situations, you are responding, providing least invasive measures before incorporating invasive measures. All right, so before we actually talk about maternal changes in pregnancy, let's spend a few minutes reviewing fetal development. I know anatomy and physiology may have been a couple years ago, so let's talk about fetal development. So in order for a fetus to actually develop, the process of fertilization needs to occur first. So this is the union of an ovum and a sperm through coitus. Coitus is the medical terminology for intercourse. And this is where you actually join chromosomes, one set of 23 chromosomes from the ovum as well as 23 from the actual sperm. So we're incorporating the biological mom and the biological dad's DNA, and this forms the actual zygote. In the zygote, there are 3 stages. The pre-embryonic stages is the fertilization process, which is occurring during the first 2 weeks. The embryonic stages occurs from week 2 through week 8, and this is where the major structures of the major body organ system, the actual internal organs, everything's happening during the 2nd through the 8th week. This is where teratogenic exposure is really, really crucial to the development of the fetus. So this is when we highly recommend for those that are planning on having a baby, to make sure that we really, really watch our diet and everything that we consume, because that may actually affect the fetal development as it pertains to the major organs, the brain, the heart, the organs, and so forth. And the fetal stage occurs at the end of week 8, all the way up to birth. And in your textbook, this is a really great breakdown of the actual fetal development. It is very specific as to what occurs during that development. You are not required to memorize this table. However, I do recommend that you do look at this just for your knowledge. For those of you who who are interested in pursuing OB, labor and delivery, and or NICU, this is very important to know for your future clinical practice. When we talk about pregnancies, we talk about trimesters. I know in our normal daily layman's term outside the medical world, when we ask patients or ask friends and families and how many months are you? So in outside the medical world, we usually refer it to months. However, when it comes to labor and delivery, antepartum, we normally refer it to as weeks gestation. So during the first trimester, week 1 through week 13 is considered your first trimester. Your second trimester occurs from week 14 all the way to week 27, and third trimester starts at 28 weeks all the way to 40 weeks gestation. So this is something you do have to know when it comes to nursing, this nursing curriculum course, as well as for your future NCLEX and ATI testing. All right, so let's talk about the placenta and the umbilical cord function. So this happens during the end of the second week. The umbilical cord is formed from the actual amnion. The placenta and the umbilical cord is the lifeline from the mother to the embryo. The cord itself contains one large vein and two small arteries. And you're asking me because I know it's very different in the adult. In the fetal circulation, it is actually the opposite. So one large vein and two small arteries. The cord itself is protected by the actual Wharton's jelly, which is the white, consistent, gelatinous component that actually protects the vein and the arteries from actually compression. And the placenta itself is an action organ that develops during the developmental stages. It actually protects the fetus from immunity attack. It removes waste. It provides nutrients and oxygenation to the actual fetus. So these two structures are very, very important to the development of the actual fetus in utero. The placenta actually produces a lot of different hormones. When a patient is pregnant, the most important hormone is the HCG hormone. This is the hormone that actually incorporates the lutein and the progesterone production. It is the basics of actually testing if whether or not a patient is actually positive for a pregnancy. The HCG hormone can be tested via the urine and or maternal serum. So when we do testing for positive pregnancy tests, we do the actual urine screening as well as the actual maternal serum screening. There is other hormones related to the development of the breast as the patient is progressing. It's also getting ready for lactation. So that is included in your HPL as well as your HCS hormone. That also helps with the maternal glucose utilization as well as glucose availability for the fetus. Estrogen is a very important hormone that is produced by the placenta. It helps with the uterus enlarging as it's accommodating the actual fetus. As the baby grows, the uterus grows as well. Not only that, it also helps get ready for the actual birth process. So the genitalia may actually enlarge and actually will enlarge, as well as stimulate future myometrial contractility, which is the actual uterine contractions. Progesterone is another hormone that's produced by the placenta. This is to actually do the opposite, where it actually maintains the actual pregnancy, where it decreases contractility actually of the actual uterus. It stimulates maternal metabolism as well as breast development as well. And lastly, the last hormone is the relaxin hormone. It acts with progesterone to maintain the pregnancy. And it also causes relaxation in the pelvic ligament as well as softening the cervix in preparations for birth. So as the weeks continue in the trimester, specifically in the third trimester, the pelvic area and the pelvic ligament, your pubic bone and the ligaments in the pelvic area will basically relax and soften. So that way a baby is able to navigate through the pelvis, expand, and actually hopefully deliver vaginally. During the development of the actual fetus, the fetus will also surround itself in an amniotic sac. This is where the fetus is protected by any type of outside exposure, outside trauma, and so forth. The amniotic fluid is derived from maternal fluid through the blood, as well as fetal urine. So for those of you who don't know, the body produces amniotic fluid as well as in combination with the fetus producing its own urine. As the baby excretes that urine, it is part of the amniotic fluid. The baby is able to actually swallow that fluid and void that fluid. Fluid is really, really important in the development of the fetus. We will talk about that a little bit later in the weeks to come. It also serves as a mechanism for temperature control for the actual fetus. Fluid is very important in the amniotic sac because it actually cushions the actual umbilical cord to be free from compression. Amniotic fluid is actually made 90% water and 2% matter, which includes the vernix, the lanugo, albumin, urea, and etc. It's alkalytic. We will be talking about assessment of the actual rupture of membranes. When we talk about the membranes, we're talking about the actual amniotic sac. Again, the fluid volume inside the amniotic sac can change. If that baby is actually taking in and digesting that fluid, it goes into the lungs, and obviously it's being excreted through the urine. The volume actually shifts based on, if you're actually doing an ultrasound, where we do an amniotic fluid index, an AFI, that number actually changes. And we'll talk about oligo, which is little fluid, and polyhydramnios, which is excessive fluid, in the weeks to come. But again, amniotic fluid is very important to function to the overall outcome of that fetus. Fetal circulation. So the fetus relies on maternal circulation, obviously for nutrients, for respiration, for oxygenation, and also the removal of carbon dioxide. This is basically the lifeline to that baby. The fetal circulation differs from adult circulation due to the presence of the vessels and the shunts. There are 3 particular shunts for fetal circulation. One is the ductus venosus, second is the ductus arteriosus, and third is the foramen ovale. The shunts will close after birth and then shunt to the actual main adult structures in the aorta, pulmonic, I can't speak, so sorry, arteries, circulations, and so forth. But the most important thing to know for a baby to transition from intrauterine to extrauterine, there are three very important structures that help shunt in that process. So for the ductus venous, it actually connects the umbilical vein to the inferior vena cava, where it actually bypasses the liver and circulates back through the placenta. The ductus arteriosus connects the main pulmonary artery to the aorta, and during this process in utero, it bypasses the actual lungs. Again, the lungs has the baby is breathing, gulping fluid into the lungs, so that way in the actual fetal circulation in utero, it's bypassing this process of the actual lungs. And lastly, the foramen ovale, which is an atomic opening between the right and left aorta, atria, it actually bypasses the actual ventricle. All right, so let's talk about, so we did a quick review over the anatomy and the purpose of the actual placenta, as well as the umbilical cord and so forth. So the patient is pregnant. The patient is going to the clinic. Usually patients, they get a confirmation that they're pregnant via the urine test or the blood test. We're going to talk about a little bit about the prenatal assessments. These are the things that we're going to talk about in the next few slides. So obstetrical history, it's important to know the obstetrical history of a patient. And the abbreviation acronym that we use is GPTPAL, GPTPAL. So G is for gravida. Gravida is the number of pregnancy regardless of the outcome of the pregnancy. So if you are a first-time mom, you will be a gravida 1. If this is your second pregnancy, you will be a gravida 2. Now, if you have twins, it does not change that number of that particular pregnancy, so it still counts as 1. There is novae gravida, which means you've never been pregnant. Primigravida means this is your first pregnancy. And multigravida means you've been pregnant 2 times or more. So again, if you are a G0, that means you've never been pregnant. If this is your first pregnancy, you will be a G1. And if you have multiple pregnancies, more than 2, you will be a G2, G3, G4, etc. Para is the number of deliveries of a fetus after 20 weeks. Anything that is, if you have a miscarriage or an abortion prior to 20 weeks, is not included in the para. And again, does not include the number of fetuses, twins, etc. So if you actually delivered a fetus after 20 weeks, a first-time mom, first delivery, you'll be a G1, P1. If you've had 2 babies, 3 babies, 4 babies, that will be reflected in your para. So you would be a G4, for example, with 4 pregnancies and 3 deliveries. So she may have had 1 miscarriage somewhere in her pregnancy. Term is considered as the T. Term is any births after 37 weeks. This does not include the number of fetus, it's just the actual term. P is preterm, so if you have a birth between 20 weeks gestation and up to 37 weeks, so 36 and 6/7. A is for abortion, so this is any loss of pregnancies before 20 week, regardless of how. We actually break it down to SAB, which is the spontaneous abortion. I'm sorry, there's a misspelling there, abortion, and miscarriage. And TAB is for TAB, which is your therapeutic termination of pregnancy. So both of those are counted as an abortion. And then L is living, which is the current number of living children that are alive after the actual birth. So G is for gravida, P is for para, T is for term, P is for preterm, A is for abortion, L is for living. So when we are caring for a patient, it's important to know their G's and P's, and of course their TPAL. All right, so let's do a sample here. Jen is a 28-year-old multigravida who is pregnant for the fourth time. She had a therapeutic abortion when she was 17 years old, miscarried at 14 weeks at 23, and delivered a set of twins at 39 weeks, both boys at the age at 25 years old, and she is currently pregnant. What is Jen's G and P's, as well as her TPAL? So I want you guys to pause this slide, read through this actual practice, and write down your answer. So let's pause, and then you can continue with the PowerPoint. All right, let's check your answers. So your answer should be G4, because she's had 4 pregnancies, including this current pregnancy. P, para, she has 1 pregnancy that reached 39 weeks, which is the current delivery of the twins. And if you break it down further, T, there should be 1 term birth of the twins. So remember, twins only count as 1 because that particular birth happened when the baby was term, which is at 39 weeks. P, no preterm deliveries, so that should be a P0. A should be 2, 1 for her therapeutic abortion and 1 for her spontaneous abortion, and L should also be 2. So therefore, her final answer should be she's a G4, P1, T1, P0, A2, L2. All right, let's talk about preconception care, which will go over the actual risk factors and address concerns that may actually affect pregnancy development and so forth. All right, when we're doing an assessment on a patient in the prenatal setting, it's very, very important to make sure that we know the patient's history. This includes her reproductive history, obstetrical history, her medical history, her nutritional status, her family status, family history, her current illness and infections, current medications that she may be taking, her psychosocial history, and of course, any history of abuse or risk for abuse. All right, so one of the things that we do need to know, first and foremost, is the actual, as part of the prenatal intake, is to determine her EDD, her estimated date of delivery, or also known as estimated date of confinement. I think most of you guys will see EDD more, but you will see that interchangeably depending on where you work. Sometimes we say, what's her EDD, what's her EDC? So in order to determine that, we use Naegeli's rule. So in order to determine her due date, we need to know her last menstrual period. When we ask the patient if she's when is her last menstrual period, we can actually formulate her due date based on Naegeli's rule. So what we do is we subtract. You may see different formulas. The easiest one for me to remember is I think about 365 days in a calendar year. So 365. So what I do is I use 371. So we subtract 3 months, we add 7 days, and we add 1 year based on her last menstrual period. That will give you your estimated date of delivery. So if you are the triage nurse, let's do this practice. We're going to do an EDD practice. You are the triage nurse, and patient Sarah presents with nausea and vomiting times 3 days. As part of your assessment, you will need to determine her EDD. Sarah shares with you that her last menstrual period was on May 21st, 2019. When is her due date for this actual pregnancy? So I want you guys to pause and calculate your EDD using Nagel's rules. So again, 371 minus 3 months plus 7 days plus 1 year. What is your answer? I'll give you guys a few minutes to calculate that. So please pause and calculate your answer. Oh, I did miss that slide. I pushed it too quickly. My goodness. So the answer is, if you were able to actually do that, I apologize for jumping ahead on the slide here, but if you're able to formulate that, if you talk about, 5 is the May, 5 minus 3 months, that will give you, the baby will be due in February. So 5 minus 3 is 2. The second month of the year is February. And if you add 7 days, so 21, May 21, if you add 7 days to 21, you will get 28. And lastly, if you add 1 year, 2019 plus 1 will be 2020. So your EDD will be February 28, 2020. And again, I apologize for jumping very, very fast on this PowerPoint slide, but we will go over it in class again. The other thing that we need to know is the fundal height. What is fundal height? The fundus is the top of the actual uterus. So as the baby is developing throughout the weeks, the baby is not only, but the baby is growing in utero. In addition, what happens is that uterus expands. So as that baby grows, the top of the fundus should match the week of the actual gestation of that baby. So you take the bottom of the pubic bone to the top of the fundus, that will give you your fundal height. So it should be equivocal. So based on the gestation, it should be equivocal to each other. And that means that the baby's growing appropriately based on the week's gestation and based on the size of that baby. All right, when we talk about viability, viability is when an infant has the capacity to survive outside the womb. Viability by law, I believe, is 24 weeks. However, due to our medical advancement technology, we have the ET tubes, the ventilator, the oscillator. We have all these fancy medical equipments to actually help a baby survive if in the event that if that baby is born prior to full term. So viability is the survival outside the uterus, the womb, and based on the actual terminology, we can actually technically save a baby between 22 and 25 weeks gestation. And I like this graph because it kind of breaks down the actual fertilization, the development, the period of the organ formation, as well as the fetal development, and then obviously based on your week's gestation, as well as your trimester. It's an overview of a little bit of everything that we've talked about previously. It's a really great slide. So this is an example of a 24 weeks delivery. Again, when you're rotating to the NICU, you will be given the opportunity to possibly be paired up with a nurse taking care of these precious little micro preterm babies. As you can see here in this photo, I love this comparison. Um, Babies that are born around 24 weeks basically are the size of a hand, your hand. So as you can see, they are very, very tiny. They're very fragile. These are your micro premature babies, and this is a set of twins, I believe. So you will have the opportunity, hopefully, to rotate to our tiny baby unit and actually see these tiny little babies in our NICU. All right. So part of the prenatal care process, when we actually first have that first prenatal visit, there's a lot of different labs that we need to collect. So that way that will be incorporated in our prenatal care. The big one that we have to know is the mom's blood type, her RH, if she's RH negative or if she's RH positive. Because in pregnancy, that will actually affect her future pregnancies, and possibly if there is any type of trauma or surgeries involved or any loss of blood volume, we definitely need to know her blood type. We'll talk about the Rh negative RhoGAM later on in our pregnancy, especially when it comes to Rh incompatibility and so forth. But let's just briefly talk about it now. So if a mom is Rh negative, and in her pregnancy, the baby is actually Rh positive, the actual maternal patient herself will develop antibodies against future pregnancies. And that can be very detrimental because because of the foreign, I guess you could say, an foreign object, the fetus being a foreign object, future pregnancy, that mom may actually produce antibodies and actually attack those fetal cells and compromise that fetus and pregnancy. So anytime there's a potential transfer or exposure to any type of blood, we definitely want to make sure that we give the RhoGAM injection in the in the antenatal stage as well as the postpartum stage to prevent future complications down the road. Another prenatal lab that we normally take is to assess for her rubella titers during her pregnancy. That's part of the vaccination. We also do an MSAFP, maternal serum alpha fetal protein testing. And again, any of these serum testing that we collect is mainly for chromosomal abnormalities. So we want to know if there's any potential risk for Down syndrome, trisomy 13, 18, 21, anything related to the actual maternal serum testing. It's to test to see if this pregnancy, if that baby is actually put at risk for all the different type of chromosomal abnormalities. Sorry, my mouth is very, very dry. If you can excuse me for a second, I'm just going to take a quick drink here. All right, so we also want to test for her CBC, which includes her hemoglobin, her baseline hemoglobin, as well as her white blood cells and so forth. We also want to test for hepatitis B because of the exposure to the actual fetus, potential transfer to the fetus. We will also collect blood to test for HIV as well as AIDS. And then lastly, we will collect cervical swab smears for any sexually transmitted illnesses such as gonorrhea, chlamydia, and GBS. This definitely will affect the prenatal development as well as the delivery process of that baby, as well as potential of infection, blindness in the future. So these are the labs that we normally collect in the prenatal setting. When we talk about cervical smears and cultures, we're looking for obviously the different types of sexually transmitted illnesses, as well as the HPV, which is the human papillovirus. We definitely want to know if there's any type of, because that baby will be most likely delivering vaginally, if the patient is positive for any type of HPV or STIs, we definitely want to make sure that we treat her, give her antibiotics and so forth to prevent any type of growth and exposure and transmission. One of the most important collection is the group beta streptococcus, our GBS collection. This is done usually towards the end of the trimester, I believe, around past 36 weeks, 37, 38 weeks, because if a baby is exposed to group beta strep, definitely that may cause neonatal sepsis in the future. So we definitely want to make sure that the patient is given antibiotics during her labor process, so that way that neonate does not develop sepsis. Different other VDLRL screening, again for syphilis, we do our torch screening, which is different types of infection that may cross the placenta to the baby and may cause baby growth issues. Again, that's your toxoplasmosis, your rubella, your STIs, your cytomegalovirus, herpes, and so forth. And we'll definitely have a future presentation on the actual infection. So this is just an overview of the different labs that we collect during her first visit in the clinical setting. All right, let's talk about fetal well-being assessment. So first and foremost, once we get confirmation that she's pregnant, the patient may also have a formal ultrasound. An ultrasound is the most definitive way to confirm a pregnancy. So basically, during her prenatal care, she'll have a formal ultrasound where they actually scan, do a fetal anatomy scan, where they're actually making sure that the baby has all of its organs, looking at the brain structure, the actual cardiac structures, the fetal development in the bones, basically looking at the overall fetal well-being of that fetus using the ultrasound. In addition to that, if there's any issues with the umbilical cord, if there is only, sometimes babies are born with one vessel, one artery, they may require future Doppler flow studies to make sure that the baby is growing appropriately. For your alpha fetoprotein analysis and your marker screening tests, these are actually maternal serums that we collect, and that is mainly to diagnose if there is any type of chromosomal abnormalities, such as spina bifida, Down syndrome, trisomy 13, 18, 21, and so forth. The nuchal translucency screening is done via ultrasound if they're, mainly specifically for Down syndrome. When they're doing that anatomy scan, at the back of the baby's neck, the nuchal area, the neck, if that baby has an increased fluid in the actual neck area, you'll see translucent fluid. If there's an excessive amount of that, most likely that baby is a Down syndrome baby. And then the next two is a little bit more invasive, an amniocentesis and a chorionic villus sampling. An amniocentesis is when we actually have to collect amniotic fluid through an actual syringe and a needle, guided by ultrasound, as you can see here in the picture. And that too is also used to diagnose the Down syndrome as well as any type of chromosomal abnormalities. The chorionic villus sampling is very, very invasive, where they actually have to go in utero and actually collect an actual sample from the actual chorionic space in the actual uterus. And that too is very, very invasive. For the amniocentesis and your chorionic villus sampling, that runs a lot of increases the risk for infection because obviously this is invasive. You're actually puncturing the actual intrauterine space. It puts that patient at risk for getting an infection as well as potentially causing preterm labor. A non-stress test is a external fetal monitoring, as you can see here in the top left picture. It's an external device where we use a machine using a sono and a toco, which is an external cable, where we place that on the mom's abdomen. Once we find out the baby's location using our I'm having a brain pause here for a second, I apologize. Using our maneuvers, we want to know exactly where the heart is located and the baby's back is located. We put the fetal heart rate tracing to trace the baby's heart rate as well as monitor the actual contractions at the top of the fundus. So for a non-stress test, basically we're tracing the baby's heart rate, seeing if the baby's in distress. We're basically seeing if the baby's oxygenated, if there's fetal well-being. We will have an actual lecture separate in module 3 on fetal tracing. So this is a way for us to actually assess fetal well-being. And last is our BPP, which is our biophysical tracing. We'll talk a little bit more about that as well. It's an ultrasound that takes in place over a 30-minute time frame where we're actually watching the baby's breathing movements, the baby's heart, cardiac movement, flexion, muscle tone, muscle movement, and so forth. All of this is to assess fetal well-being. So these are the different types of procedures and testing that we do to see how well this baby is doing. All right, in the next couple slides, I kind of did an overview of the actual procedures as well as the actual diagnostic testing. Please make sure you take the time to actually read the actual fetal, why we do this, when we do this, and how it's performed. Same thing for the marker screening, the nuchal translucency screening, the amniocentesis, the CVS, the NST, as well as your BPP. So please make sure you review these two graphs. All right, let's talk about signs of pregnancy. When we talk about signs of pregnancy, we use 3 different ways of categorizing this. First is our presumptive, which is our subjective measure based on what the patient is reporting. Probable is the objective confirmation via diagnostic screening and testing, as well as your positive, which is your diagnostic confirmation. We're going to dive into this and explain all of this in detail. All right, so signs of pregnancy based on presumptive signs and symptoms. And this again is based on the patient's, what the patient reports and what the patient feels. So when a patient has presumptive signs, she is experiencing amenorrhea, which means she's no longer having any periods. She may experience fatigue, because when you're pregnant and you are growing a fetus inside of you, another human being, it takes a lot of energy. It sucks a lot of energy out of you. So that patient may actually experience a lot of fatigue. In addition, in pregnancy, she may also experience nausea and vomiting, increased urinary frequency, changes in her pregnancy. She may feel sore, and so forth. And between the weeks of 16 and 20 weeks gestation, she may feel a quickening movement, a little bit of a flutter. Some patients may not actually feel the actual fetal movement or the actual fetal flutters. Some may actually feel like gas bubbles and things like that, a little gassy pockets. And obviously, as that baby grows, the uterus is enlarged and grows as well. Probable signs of pregnancy. So again, this is the objective way of identifying signs of pregnancy. So the abdomen is enlarging, the uterus is enlarging. There is a positive pregnancy test via the, a lot of times patients can go and buy the over-the-counter pregnancy test at Rite Aid, Walgreens, and so forth. And then obviously, if that baby is growing, they're able to actually palpate and feel the fetus, and they actually outline the structure of the actual fetus. The next 1, 2, 3, 4, 5 terminology, please make sure you guys know this very, very well. This will be on your exams, and ATI, and also potential your NCLEX. So Braxton Hicks are actually contractions where the uterus actually contracts. It's very, very normal. These are your very mild contractions that last, for a very short period of time, usually like less than 1 minute, 40, 60 seconds, 30 seconds. These are just contractions that are not indicative of actual labor. Hager sign is the softening of the lower uterine segment. So as the uterus grows, as the baby develops, as the weeks gestation continues, as labor starts to come closer, the actual uterus will actually start to the lower segment will start to soften to help expedite that process of labor and delivery. The Goodell sign is when the actual cervix is actually softening, again, in preparations for labor. Chadwick sign, and this is when you actually have a little bit of a bluish, kind of darker color in the cervix and the vagina as part of your assessment. This is a probable sign that the patient is actually pregnant. And you think about Chadwick, think about bruising. Chad is a bully and he's beating you up and he causes trauma or any type of bruising to your body. So Chadwick, bluish, darkish, changing of the cervix and the vagina. Ballottement is when a fetus is growing in utero. Again, it's being cushioned by the amniotic fluid. It's free floating inside the actual abdomen. So when you do a pelvic exam and you push the actual fetus, you can feel that it's bouncing, floating, rebounding. It gives you like a rebounding effect. So basically, this is the actual ballotment of the actual fetus. So that baby has not progressed down the pelvis. It has not engaged in the pelvis. It's basically free floating in the abdomen. All right, positive signs of pregnancy. So we talked about having a formal ultrasound, and via ultrasound we can visualize and verify that there is an embryo, a fetus growing in utero. So that is a diagnostic way of actually diagnosing pregnancy. And also via the actual Doppler and or sonography, where we can visualize the actual fetal heart and the chambers of the heart actually beating. That is a positive confirmation that there is an actual fetus. And lastly, fetal movement, palpated by the provider and or the patient. These are positive signs of pregnancy. All right. So now we are going to dive into our physiological changes in pregnancy. As you know, there are a lot of changes occurring during pregnancy. Fetal development changes the environment. The way God made our female bodies is so amazing and such a miracle. It's amazing what the female body anatomy goes through to be able to actually create life, develop the fetal, help assist in fetal development, as well as the whole process of the pregnancy changes, which will eventually help facilitate the actual delivery of the fetus down the road. So there's a lot of changes that occurs during the reproductive stages. I don't really want to spend a lot of time. You can actually make sure that you read your modules, and I will please take a moment to review the changes in the uterus, the cervix, the vagina, the ovaries, as well as the breast. And a lot of this we've talked about already. So please pause and review this if you need. All right, let's talk about the GI changes. That we have not talked about. So during that, as the baby's growing in utero, it really definitely affects a lot of the GI symptoms that the patient may be experiencing. As that baby grows, most importantly, as you know, it's growing and taking up a lot of space in the actual uterus. And what happens is, as that baby grows, it's pushing up on the diaphragm, on the esophagus, in the stomach region, and so forth. And a lot of this does increase the nausea, the vomiting, the heartburn that that patient may be experiencing. Polytolism is increased salivation. So again, that may be happening in the mouth. The gums may be friable, really truly at risk for actually bleeding, and also at risk for developing gingivitis. Because that baby is growing and pushing on the esophagus, patients a lot of times will experience heartburn and reflux, especially if they eat a lot of spicy food. So during pregnancy, and I remember myself, man, that was definitely very uncomfortable. So I often carried Tums with me a lot of the times just to help with that heartburn sensation. So depending on the need, patients may need to take some Tums. And if it's really, really, really bad, they may actually need physician's order for medications such as simethicone and or antacids and so forth. So depending on how severe it is. Because everything is being elevated, pushed around, there's not a lot of room in the stomach. This does cause a delay in the gastric emptying and the slow digestion of the actual food and so forth, which may cause a lot of the nausea and vomiting. So it's highly recommended that patients actually eat small, frequent meals to prevent the delay, gastric emptying, and digestion. When it comes to the intestines, everything is actually slowed down. Everything slows down. So that decreases your motility, which obviously increases the risk for constipation and gas. So very, very important to make sure that we recommend a lot of fluids, a lot of high fiber foods, and so forth. And because of all of that extra pressure, so normally when when you think about the fetus, the weight of the fetus, the weight of the placenta, the weight of the fluid, that can be an extra 30, 40, 50 pounds of weight that's being pushed on the actual rectum. So a lot of our patients do have hemorrhoids in pregnancy, and it can definitely be uncomfortable for patients. So they may actually require some medications to alleviate that pain of the actual hemorrhoids. When it comes to the gallbladder, everything in the gallbladder is decreasing. So the tone in the gallbladder, the motility, and the excretion of the actual biliary tract, everything's starting to slow down. So these patients are at risk for actually developing gallstones, and they can actually develop a lot of nausea and vomiting as well. So a lot of it's pretty common for patients to have cholecystitis, cholecystectomy because of the actual formation of the gallstones during the pregnancy. All right, so when it comes to cardiovascular, it's fascinating that the way our bodies are created by God, we normally, as human beings, have about 1.5 to 2 liters of blood, a normal adult. However, in pregnancy, because of the pregnancy process, because we are the lifeline, we as a woman, we are the lifeline. We're providing nutrients and oxygenation to a growing fetus in utero. Our blood volume actually doubles. So we may actually have increased the blood volume by two times. So a patient may actually have up to 4 liters of blood. So because of the blood volume, that actually causes an increase in the cardiac output, as well as it may also increases the patient's heart rate. So blood volume. So this, because of the blood volume, we're in a hypercoagulable state. So there's an increase in RBCs, there's an increase in plasma, there's a lot of increase in the different blood products, so that way we're able to provide that nutrient to the fetus that's growing in utero. Because of this phenomenon, it does actually cause physiologic anemia because of the increase in the blood volume. There is actually no increase in hemoglobin or hematocrit. So it causes a hemodilution in our blood volume, which may cause anemia in pregnancy. Also, because of the increase in blood volume, because of, again, the increase in RBCs, fibrin, fibrinogen, blood clotting agents, pregnant patients are at a higher risk for developing deep vein thrombosis, or DVTs. So we definitely want to make sure that we educate our patients, obviously, to make sure that we're using proper leg compressions, elevations of the leg, and things like that. A lot of times patients that are admitted in pregnancy during their antepartum stages, because of this high risk for developing DVTs, if they're on the inpatient side and they're being admitted, the majority of those patients are given heparin or some type of anti-DVT development. We want to prevent all of that, different interventions and apply different interventions and so forth. The heart usually shifts up and to the right because the baby is growing and it's expanding into the diaphragm. The patient may experience some shortness of breath and things like that. So because of all the movements, all the shifting, and the decreased sides for expansion of the actual respiratory system, I'm so sorry, we're talking about cardiac here. It actually does put a lot of pressure on the actual heart. You may see a decrease in the diastolic, and you definitely want to monitor and watch signs for preeclampsia, which is a pregnancy complication in regards to hypertension. And we will definitely have a different lecture on preeclampsia. We definitely want to prevent any type of edema, which is pretty common in pregnancy, varicosity veins, hemorrhoids, anything we can do to help alleviate any of that. All right. When it comes to the cardiovascular system, we talked about the weight of pregnancy, and when a patient lays down supine, that pressure, all that weight of the fetus, the placenta, the fluid, if a patient's laying flat on her back, it's actually pressing on the inferior vena cava, the aorta. When that's happening, a lot of the times the patient may experience hypotension, tachycardia, because of the hypoperfusion. Patient may experience dizziness, weakness, lightheadedness, and things like that. So that's why it's very important to make sure that we educate our patients and have them sleep on their side. A lot of times when they're sleeping in bed, we want them to sleep with a pillow wedged behind their back. On the second bottom right photo, we want to alleviate all that pressure on the inferior vena cava as well as the aorta. So that way the baby can actually get the full perfusion um, oxygenation and nutrients, and it also alleviates the patient from actually experiencing the inferior vena cava syndrome. Physiological changes in the respiratory system. So we had talked about a lot of the, as the fetus is growing in utero, the uterus is growing, everything's being pushed up into the diaphragm. This definitely does affect the respiratory system. As you can see, it increases the O2 consumption rate. Patients may be breathing a lot faster because of the decreased volume and the expansion of the actual respiratory system. They may experience some shortness of breath because of the actual pressure on the diaphragm. They may also have difficulties breathing due to nasal congestion or allergies or epistaxis, which is nosebleeds. A lot of allergies and things like that may increase based on the vascularity that occurs during pregnancy. All right, when it comes to the vascular, we talked about the respiratory system. Let's go into the renal and urinary changes. Due to pregnancy, the kidneys and the bladder definitely decreases the tone. However, it does increase the capacity of the actual bladder. And a lot of times, because of the increase in the capacity, the actual ureters, everything that's weighted on coming from that weight of the baby, the uterus, the placenta, all of that is pushing on the actual bladder. This actually increases the frequency of the urination. It's very, very uncomfortable. So patients a lot of times do use the restroom a lot, which is very uncomfortable, especially in the middle of the night when you have to go multiple times. Blood flow to and filtration through the kidneys actually increases. Yeah, I mean, hydration is very, very important. However, the pro does outweigh the risk, but it does increase a lot of the urinary problems and so forth. When it comes to the musculoskeletal changes in pregnancy, we had talked about the hormone relaxin, which is one of the hormones that the placenta actually produces. As the patient progresses in her weeks gestation, you can see there's a shift in her body, the skeletal, musculoskeletal system. As she grows, you can see the spine changes and causes lordosis, which is this excessive inward curvature of the actual spine. So especially towards the end of pregnancy, you'll see a higher lordosis because of the balances of the actual physical structure. At this time, the patient may also be walking, having that waddle walk because of the relaxin hormone that causes the pelvis to relax, the ligaments to relax. All of that may change the way her posture is, as well as her lower extremities. She may be waddling. Again, all of this is to prepare her body for labor down the road. All right, so the other thing that we need to know is the changes in the integumentary system. There's a lot of changes in pregnancy when it comes to the effects of the actual skin. The hyperpigmentation, so a lot of times patients do experience hyperpigmentation during pregnancy because of the extra hormones. Which basically exacerbates the melanocytes and so may cause the actual the facial melasma as well as the abdominal melasma. All of this, please make sure you guys know the terminology, the definition, specifically this gravidarium, which is the stretch marks, and so forth. I know I feel like I'm going very fast through these slides, but please make sure that you take the time to pause if you want to read more about these. We did talk about the placenta developing all the different hormones in the endocrine system. So these are the different hormones that affect pregnancy. So please make sure you take a chance to read that and review that as well. And obviously, the two that I did not talk about at the beginning of this slide is prolactin, which helps to produce milk production, and that usually does occur during pregnancy, and the letdown process. Oxytocin, which is another hormone, also known as the love hormone, it stimulates uterine contraction, the actual bonding of the fetus, as well as the actual milk ejection. All right, when it comes to the immune system during pregnancy, it enhances innate immunity. So again, in pregnancy, internally, there's a lot of great things that happen. And because the pregnant woman is growing the fetus in utero, there is a boost of immunity in pregnancy that helps to prevent any type of attack on that actual fetus. A lot of times, it's so important during this time that mom maintains her health, especially her diet. Obviously, we want to decrease any type of exposure to infection, so that way she doesn't get sick, as well as her newborn. There is a lot of correlation in studies that if the patient's immune system is low, when the patient is prone to infections and things like that, it does actually affect pregnancy and cause complications in regards to, sepsis, preterm labor, and potentially even the loss of a neonate. So just an FYI for you to know. You don't really need to memorize anything on this actual slide, but please make sure you just review it and know that it's amazing how our bodies are made, right? All right, so let's talk about nutrition during pregnancy. Obviously, as a pregnant patient is developing her pregnancy and growing this fetus in utero, it's very, very important to make sure that we educate and promote a healthy diet. And a lot of that comes from our nutritional needs. A lot of times we can prevent spina bifida, diabetes, a lot of different complications to the fetus if mom has a healthy diet. So again, we highly recommend a high protein diet and iron, especially if she's anemic, and obviously folic acid can be found in all of these nutritious food. And definitely, we highly recommend that the patient takes her prenatal vitamins as well as her folic acid medication. So this is just something that we definitely want to make her recommend as she is growing her, providing nutrients and oxygenation to her fetus. And I love this photo on the right-hand side. It's taken from the Oregon Health Science University. It just shows you the a healthy pregnancy plate, the things that we should be consuming in pregnancy. Obviously, we want to stay away from the fast foods, junk foods, and things like that. All right. So when it comes to weight gain during pregnancy, every patient is unique, obviously, depending on how they present. Based on the patient's BMI, the changes will occur based on her diet, the growth of her baby, a little bit of everything. So the recommended weight for a normal patient, the average patient, should gain at least 25 to 35 pounds during her pregnancy. Again, that does change based on whether or not you're underweight or overweight or obese. Obviously, If you're obese, we don't want you to gain 25, 35 pounds. However, if you are at normal weight, we do want to recommend that you gain, because that means that the fetus is growing appropriately based on the size and the weight and so forth. So please review this slide. Very important to know. You definitely will be tested on this material. Emotional and psychological changes. Again, as a female body grows and develops, there's a lot of changes that's happening and occurring in pregnancy. This may affect her psychological, mental status. Some patients embrace pregnancy and love pregnancy and the changes in pregnancy. And there may be some patients that do not like the changes that are occurring in pregnancy and so forth. So besides that, they may have encountered some changes in their body image. They may also experience mood swings because of the fluctuations in all the different hormones. It's interesting to know the Couvaid syndrome. This is when the actual partner experiences similar pregnancy symptoms. So it is a real thing, specifically when it comes to eating and growing the abdomen and so forth. So anyways, just a cute picture to show you. The next slide we want to talk about is to make sure that the patient is taking care of herself during her pregnancy, and definitely want to minimize any signs of any discomfort that she may be experiencing in pregnancy. In the next couple of slides and graphs, it will talk about the different changes in pregnancy and make recommendations on things to help alleviate those signs and symptoms of discomfort. So please make sure you take a time to kind of review all of this, and so that way you can educate your patients down the road. All right, so follow-up visit. So we talked about the prenatal setting, the first initial visit, and the things that we need to collect based on her labs and her serum and all the different types of testing and so forth. This is just a breakdown. So usually during the first trimester, the patient's prenatal care, she usually schedules her appointment every 4 weeks. During the second trimester, usually it's every 2 weeks. And then when it comes to 37 weeks, between second and third trimester, between 29 and 36 weeks, usually it's every 2 weeks. And then towards the end of her trimester, between 37 weeks and on, the physicians, providers, midwives will schedule a weekly prenatal visit just to check up on that baby and that mama. And then, so that's right there is the breakdown of the different visits and what we normally do. Very important to know the danger signs in pregnancy. Please review this chart for your first trimester, second trimester, and third trimesters in pregnancy. Obviously, if there's any of these danger signs are occurring, we definitely want to recommend that the patient calls her provider and or goes to labor and delivery, so that way she can be assessed immediately. Anything related to vaginal bleeding, any type of leakage of fluid, trauma, if the baby decreased fetal movement, if the baby's not moving, we definitely want to make sure she gets seen ASAP. We don't want to have a fetal demise, which means the baby passes away in utero. So these are the danger signs in pregnancy. So please make sure you review these signs and symptoms. So that way you can educate your patients. Definitely will be tested on this material as well. All right, so we talked about the fetal kick count besides making sure that we teach them on the danger side, danger signs. We also want to make sure we educate our patients on fetal kick counts. On average, I love this photo. I do believe it's a little bit airbrushed or created, but you really won't see an actual footprint, but you will see the baby actually moving around, kicking, prodding. You may see the pointy spots of the elbow or the knees or something like that, but this actual picture is not, I think is actually airbrushed. Anyhow, I love it though. It does show that, we want to make sure that babies are moving, and they should be moving 10 times within the hour. This indicates when the baby is moving in utero, this indicates that there's fetal well-being. That means that the baby's oxygenated, the central nervous system is intact, that baby is healthy, that baby's moving. If you can compare yourself, if you get hypoglycemic, you're a little lethargic, you should be active and running around, right? So same thing with the fetus, the baby should be moving around. Now, there will be times, everybody has a different schedule. Normally, babies are more active during the evenings and nights and less active during the day. So please make sure that patients know what their baseline is. If that baby isn't moving as much as it usually does, we definitely want to make sure we recommend that the patient drink some ice water, some water juice, some juice or something like that. Turn on the side, lay on the side, and increase that perfusion to that baby to help that baby get more oxygenation and nutrients. And obviously, if that baby does not have any change, we highly want to recommend that baby go to labor and delivery. I'm sorry, mama goes to labor and delivery. All right, so that concludes our presentation on the maternal changes in pregnancy and all the important signs and symptoms of pregnancies, as well as the assessment and fetal well-being screening. Again, just a reminder, you are responsible to please make sure you go into your modules, read the assigned reading. We may not cover everything in detail here, but you are ultimately still responsible to make sure you read the content. Please don't hesitate to reach out if you have any questions at all. We are here to assist in your learning, and thank you so much for your time. Have a great day.